This episode of Us and Them is supported with a grant from the Claude Worthington Benedum Foundation.
Hey, Trey K here. The pandemic has changed so many things. How we get our groceries, how we see our families, even how or whether we go to work. COVID-19 has also changed our healthcare systems, including how people access mental health treatment and counseling. Most providers have expanded access to telehealth visits. But for some patients, a therapy session on video chat can be tough, especially here in Appalachia, where internet connectivity is a challenge. From PRX and West Virginia Public Broadcasting, this is Us and Them. It's the show where we tell stories about the things that divide us. I'm Trey K. More than 60,000 West Virginians struggle with an eating disorder. These mental health conditions are complex and can affect people of all ages, genders, and backgrounds. The disorder can affect a person's physical health and become really serious if left untreated. Dr. Jessica Luzier runs the West Virginia University Disordered Eating Center in Charleston, West Virginia. Their program brings psychologists, social workers, a registered dietitian, and physicians together to care for their patients. When the pandemic hit back in March, their team had to change its approach to treatment and collaboration. They also needed to address the isolated nature of sheltering in place and social distancing, because that can exacerbate an eating disorder. I sat down with Jess on a video chat to find out more. I think one of the first things that I would really like to understand is, how do we define an eating disorder?
I would define it as a serious medical illness that's marked by a pretty severe disturbance to a person's eating behaviors. So different signs might include obsessions with food, obsessions with body weight, size, or shape, and resulting in a change in behaviors that are very concerning, including, for instance, binge eating behaviors, compensatory behaviors like purging by vomiting or abusing medications, and a severely disturbed ability to see yourself and a disturbance in the way you judge yourself and your body shape.
And during a time of heightened anxiety like we're experiencing during this pandemic, how are you seeing this manifest with the patients that you see?
They face some unique challenges. One of the biggest ones is food availability. So we have a lot of research to suggest that when there's questionable food availability, we see a higher rate of disordered eating behaviors. And so certainly that is the case for our patient population. We see them struggling with possible compromises in their health, such as being less immune to viruses like the coronavirus because they're already medically in some trouble as a result of disordered eating behaviors. And we see them really struggling with social media and media consumption more generally, too.
And with the media consumption, I guess that could possibly drive up anxiety with regard to food availability. I mean, if you are seeing, like, we can't go to the grocery store, or that there may be some type of disruption in the food supply, we see prices going up. I mean, those types of things, if you read the newspaper, if you watch cable news or something like that, and you are somebody with an eating disorder, I guess you're going to tell me that's a trigger, no?
Absolutely, it's a trigger. And you're right. We're hearing a lot about it. We're hearing a lot about disruptions to the supply chain when it comes to certain foods. Many of us who have been in a grocery store in the last few weeks have noticed portions of the grocery store where there are empty shelves. And so, absolutely, that's a very severe trigger for people who struggle with disordered eating.
I would imagine that treatment needs to come in a regimented, consistent manner, and that to have these routines disrupted, it's not a good thing, right?
Absolutely. You nailed it. This has been very disrupting to people's lives and to their ability to not only access treatment, but to fully participate in treatment in a way that we really want them to be prioritizing it in their lives. Treatment plans for people with eating disorders include psychotherapy, medical care, and close monitoring, nutritional counseling, sometimes medications, and oftentimes a combination of all of these different approaches. And so to juggle all of this, even in regular face to face outpatient clinics, can be tricky. But to do it virtually or to be limited in how much you really should be coming to the hospital is especially problematic.
So, what's happening in your organization? Are you all kind of getting together in a conference room or getting on Zoom or whatever you would do at that time and say, what are we going to do? Or is your hair on fire? I mean, how are we going to treat this significant number of people who need our help?
Yeah, I think all of the providers needed to mobilize very, very quickly. And I'm really proud of my team because our priority remained focused on patient care.
So,
How
so your
can we
hair
live?
wasn't on fire. You were.
Well, I wouldn't say that. I mean, there were moments where our hair was on fire. And we try to make lemonade out of lemons. And how can we just find a way to make this work? As opposed to focusing on how terrible it is, even though it is terrible.
Had you been doing telehealth at that point?
Well, I think there were some providers in our department that were using telehealth, primarily the psychiatrists in our department. But no, none of the psychologists in the department had been using it, nor had our registered dietitian been using it. So that was a scramble to get up to date on the platforms and to learn all the nuances of telehealth too, because there's a whole nother set of rules and risks and benefits
This
to
isn't
telehealth.
this isn't just like calling your grandmother who's in a different
No
part of
way.
the world or checking like there's what are the other things that just so people know, what are the other things that you need to consider?
Well, there was a scramble in the early days with the insurance companies to see whether they were going to cover telehealth and under what conditions they would cover it. So, for instance, we weren't sure initially whether phone calls would be covered versus audio visual or virtual visits that had to have camera capabilities on both ends of the line. We weren't sure whether we or our patients had the technology that we needed to deliver telehealth. As I'm sure many folks are aware, there are plenty of places in our state where Wi Fi or broadband just isn't available, nor can all of our patients afford an iPad or a tablet or a laptop or even a smartphone upon which they could receive telehealth. Some of our patients and even some of our providers were particularly comfortable with it. So we needed to learn about it a little bit more and really understand the ins and outs
You're
of
saying
it.
they weren't comfortable with it? Okay, yeah,
Absolutely.
okay.
Yeah, and I would include myself in that. I really wanted to learn more about telemental health delivery before I got rolling, but that needed to happen very, very quickly.
What was the reaction of your clients, of your patients?
I think most often their reaction was fear. I think a lot of us reacted to the stay at home order with fear. But I would say their reaction to our offer to deliver them telemental health was relief. They were so glad that treatment could go on for the most part. Now, some have been skeptical, understandably, of connecting with their providers through that manner. But like I said, most were very relieved. And for most, it's really gone swimmingly. They've been able to jump right on and really continue treatment with as few bumps as possible.
Okay, we got our patients in care, but what about those ones who hadn't really gotten into the system yet?
That has definitely been our trickiest patient population, were those who are just getting started with treatment, who maybe hadn't quite bought into treatment or hadn't been fully oriented to treatment yet, who hadn't developed relationships with their providers, which makes treatment so much more meaningful for our patients. Or for folks who hadn't even gotten a foot in the door yet, because there were some disruptions just in the first week or two with getting new folks in. And, it's an interesting and odd experience to meet somebody for the first time through a video conference.
Right, right. Yeah, I mean, it's very nice meeting you, but it would be nicer just to meet you some way other than a Zoom link.
Indeed.
Yeah. So what are the triggers, the things that can really cause despair and dangerous despair with people who have eating disorders during this time?
I've already mentioned food and food availability as a really significant trigger for our patient population right now. But in addition to that, the preoccupation with social media has also been particularly problematic. We've had patients describe to us just how distressing it is to scroll through their social media all day, every day. And unfortunately, many of us are getting sucked into that trap during the stay at home order as well. But that's particularly dangerous for
Why? Why?
somebody.
Why is it?
Yeah, so there's lots of research suggesting that even if you don't have an eating disorder, that scrolling through social media results in folks feeling worse about themselves. In particular, for people with eating disorders, scrolling through social media can even lead to different disordered behaviors, like your likelihood of binging, for instance, is greater the longer you scroll through social media. Your likelihood of severely restricting or over exercising or using another type of eating disorder behavior like purging is much greater the longer you scroll through social media. So that's been one that I've been watching very closely in our patient population, and one that concerns me quite a bit.
Well, okay. Can we just pretend for a second? Say I'm one of your patients. What kind of questions would you ask me to kind of get some type of an assessment of what may be triggering me?
Well, specific to social media, I would want to know what your uptake is every day, which most of our phones can tell us that, believe it or not. I don't know if you've ever looked at that at your phone, but it's quite alarming, frankly. It tells you how many times you pick up your phone, how many times you scroll through which apps, et cetera, et cetera. And then I would want to be asking my patient, what kind of effect does that scrolling have on them? What sort of urges do they have as they're scrolling? Do they notice a difference on days that their uptake of social media is greater or lesser? And try to identify some patterns, so that we can better understand if this is something that's effective and helpful to them, or if it's not. And if it's not, it's not a matter of cutting it out altogether. It can even be a matter of helping our patients to be a little bit more media literate, to helping them to understand that the folks that perhaps they're following on some social media platforms maybe don't actually live the lives that are portrayed on those social media platforms. Or perhaps there are some areas of social media that would be healthier for our patients to be spending time on versus areas that they find very triggering.
After a break, we'll learn about particular eating disorders that are most concerning because of the health consequences they present for patients. You're listening to Us and Them from PRX and West Virginia Public Broadcasting. Our show is supported in part by the West Virginia Humanities Council and the CRC Foundation. This episode is supported with a grant from the Claude Worthington Benedum Foundation.
In difficult times, music gives us peace, brings us together, and helps heal us. It calms our nerves and brightens our days. That's why we're bringing you classic episodes of Mountain Stage on air and in our podcast. This is Larry Gross, host of Mountain Stage. Find something that's familiar or brand new and feel the power of live music on our website, mountainstage.org.
Hey there, Trey here, and you're listening to Us and Them from West Virginia Public Broadcasting and PRX. I'm speaking with Dr. Jessica Luzier, who runs the West Virginia University Disordered Eating Center of Charleston. She says while all mental health disorders can present immediate threats for patients, some are potentially more dangerous.
I certainly have concerns about all of my patients with eating disorders, but I would say I have the most concerns about my patients with a disorder called anorexia nervosa. So people with anorexia nervosa avoid food, they severely restrict how much they eat, they might eat very small quantities, and they are typically dangerously underweight, even though they may see themselves as overweight. So it might surprise you to hear that anorexia nervosa actually has the highest mortality rate of any mental illness. And so there are more people who die of anorexia nervosa than of any other mental illness. And that's in part because their bodies are in starvation or semi-starvation states, and they're very medically and psychiatrically compromised.
I would imagine if you're separated from them, you would worry about them greatly. And how is it that you can actually? I know sometimes like you want to be with the client, you want to be able to palpate, you want to be able to look, you want to see their records, and you are separated from that.
Right.
How is that for you?
It's taken some getting used to, but I think that there are ways to make it work. And it's more effective if we have good relationships with that patient support system, if they can be with people who can help them to be accountable
Right.
for maintaining their recovery behaviors.
So that could be a
But,
parent or a spouse or right.
But we're asking patients to literally take their own blood pressure and while we're on their video conference with them and report back to us. In some cases, when it's appropriate, we're asking patients to report their weight to us, especially if that's something we're really worrying about. And boy, we sure wish that we had the ability to do that in the clinic where we can control those variables more effectively. But again, we've got to be able to adapt.
But I guess when you're saying that, are your patients always reliable narrators with regard to giving you the information that you want, or that not just you want, that you need to have to effectively treat them?
That depends. Part of having an eating disorder is sometimes really questioning whether you have an eating disorder, or minimizing the perceived risk in your malnourished state. And so, certainly, those are going to be variables that we're watching very closely in our patients, and we're talking very openly with them about what their urge to lie to us is, or what is the eating disorder telling you right now about how perhaps you could cheat on some of these measures. But for most of them who have good, trusting relationships with us, they're able to disclose when that's happening. And again, we have, thankfully, an interprofessional team where there are 2 or 3 people asking them similar questions a couple of times a week and really maintaining that close contact. So if they begin to slip or lapse, we try to catch it as early as possible and get them back on track. And remember, worst case scenario, we can bring somebody into the hospital or into the ER if they're really in medical trouble. Although it gives me pause before I send somebody to the ER at this point in the pandemic. I've really got to weigh the risks and benefits of doing that.
There is a certain type of professionalism that 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 needs to happen, in a therapeutic treatment situation. When you're talking to somebody, through a video connection, you don't have as much control there. There's much that you can't see and observe from them, but there's also things that you have to kind of be aware of with regard to where it is that you are on the other end of the camera.
Yeah, it's certainly something that I've had to deal with. I've elected to conduct my clinical work from my office, which is located inside a hospital, and taken all of the precautions necessary to come in and be safe when coming in and out of the office. But plenty of people have been conducting clinical work from home, even some of our treatment team members on the eating disorder treatment team. And I have been humbled by how much grace our patients have given to us during this time. I mean, it is not typical for my patients to be asking me how I'm doing and asking me if I'm safe and my family is safe. And in fact, when we were in our training, we were sort of taught to steer out of conversations like that. And yet, right now, conversations like that feel very human.
We were talking before about anxiety over access to food. We're really in I still think the early salvos of what this is going to be. And I think part of what this is going to be is that that a lot of people economically are going to be in bad shape. And whether or not they're going to have access to food, whether or not they are going to have confidence that the government or even their families are going to be there to help them. Their community is going to be there to help them with some of their basic needs. And I guess if you think about that, I guess my question to you is, do you think about that? And how do you factor that into maybe the care that you're going to give people moving forward?
Yeah, I certainly think about that. not only when I'm doing everything I can to try to help my patients build their resilience in the long run and their coping strategies and prevent relapses, but also from an economic standpoint, when I'm considering how important it is that my patients get good care now in case they do lose their jobs or in case they are unemployed or lose access to health care as well. And that's what worries me most about the potential economic downturns that we may face, is whether folks are going to lose the ability to go get the treatment that they need. To me, that would just be so devastating.
That's Dr. Jessica Luzier, who runs the West Virginia University Disordered Eating Center of Charleston. The center uses multidisciplinary teams to work with people who have eating disorders. You've been listening to Us and Them. Our team for this show was me, Trey Kay, Brittany Patterson, and Kate Smith. Michael Lipton and Tristan Lozow wrote and performed the Us and Them show music. Mark Lerner designed our logo. Lelena Price provides us with images for the web. The marvelous people at PRX and West Virginia Public Broadcasting make Us and Them possible. So do grants from the Corporation for Public Broadcasting, the West Virginia Humanities Council, and the CRC Foundation. This episode is supported with a grant from the Claude Worthington Benedum Foundation. Us and Them was originally developed with assistance from the Mentorship Program at AIR, the Association of Independents in Radio. We'll see you next time on Us and Them.
Support for this podcast comes from the Corporation for Public Broadcasting.
From PRX.